So, without too much further ado, here's tonight's lineup. First talk, Sexual Wellness and the Future of HIV by Dilla. And then, behind the mic, titillating podcasts. And that is Mariah Gossett. And then, returning to our stage will be Adam Maurer, talking about what can kink do for you? Yeah. All right. One more big round of applause to welcome Dilla to the stage.
So like any good trainer, I've already changed the title of my slide from what you saw in the opening. And I have so much information that I want to share with you that I'm not going to waste a lot of time talking about myself. But I do want to give you just a little background. So I do go by Dilla. I've worked in HIV since 2000. I started running a comprehensive sex ed program for high school age kids in Kentucky, and then I've done a little bit of everything since then. So I'm going to talk a little bit more later about the work that I'm doing right now. But first, I want to take a look at how far we've come in the last 40 years and why I'm screaming so much about barebacking all the time. So, major disclaimer, I am only talking about HIV in this conversation. I am not talking about preventing or treating other sexually transmitted infections, including pregnancy. So, 40 years of HIV in about 5 minutes. Here we go. Now, we know that HIV's been around a lot longer than this, but it first came to the attention of the medical community in 1981. First identified as a rare cancer among gay men. It was called GRID, gay-related immune disorder. This later became known as AIDS, and then shortly after that, we identified the virus called HIV. Now, 2 years later, the FDA approved the first drug to treat HIV, AZT. AZT was originally developed as a cancer drug. The evidence behind its efficacy for HIV was scant. Many scientists on the committee didn't want to push it forward, but it got pushed out anyway. It had tons of toxicity. It ultimately killed a lot of people, and any positive effects it had were very short term. In the same year, building off the decades of activism of the gay liberation movement, ACT UP, or the AIDS Coalition to Unleash Power, yeah, scream for that, was formed to protest and force the federal government to respond to the growing pandemic. And at this point, there had been no significant response from the federal government, and the president, Reagan at the time, publicly refused to acknowledge HIV in any way. Finally, in 1990, almost a decade after we first saw the first cases, the federal government authorized the first significant funding to fight HIV, the Ryan White Care Act, named in honor of Ryan White, a teenager from Indiana who had become a public face and advocate for people living with HIV because he was palatable, because he got it through a blood transfusion, not through butt fucking. So he became the poster, and the legislation was named after him when he died. Now, move up to 1993. Here we go. So prior to this, the conditions that defined AIDS were based on what diseases were being seen among gay men. There was a mistaken belief that women didn't get AIDS. They were just vectors of HIV and a disease, but they didn't get sick from it. And so nobody looked at how it manifested in women. Having an AIDS diagnosis is really important because it meant access to medications and access to disability insurance. In 1993, the definition expanded to include several new opportunistic infections, many of which were specific to women. And this saw a sharp increase in the number of people that were living with AIDS. Now, AIDS deaths reached a peak in 1995. The leading cause of death among men aged 25 to 44 in the US in 1995 was AIDS. In 1995, just under 49,000 people died from AIDS in the United States. And from the beginning of the epidemic up until this point, 320,000 people died of AIDS. 320,000 artists and writers and teachers and politicians and doctors and freaks and fuck-ups and role models. 320,000 gay men and queers, an entire generation of activists and role models were lost to AIDS. And we'll never know what this world could have been like with a minute. Fortunately, in 1995, HAART, or highly active antiretroviral treatment, was introduced. HAART was also called cocktail therapy, and it was a literal lifesaver. You'll hear a lot of people from this time talk about the Lazarus effect that it had almost instantaneously on those who were on the brink of death. And we saw a rapid and sharp decline of deaths within 2 years. However, HAART meant multiple pills, multiple times a day, and so it wasn't really easy to tolerate, and a lot of people weren't able to maintain on it. In 1996, the viral load test was approved, and for the first time, we were able to see how much of the virus was in the blood, and we were able to tell when it was undetectable, which let us know that medication was working and that it was effective. And ultimately, this became our understanding of viral suppression and what that meant for passing on the virus if you were on treatment. Now, the 2000s saw the beginning of the Bush administration. This was also my entree into the HIV world. And we saw significant additions to federal funding for abstinence-only sex education. Now, sex education in the 2000s now meant two main things. A, you had to require programs to say that sex outside of marriage was psychologically and physically damaging. And two, you could only talk about contraceptives and safer sex to talk about their failure rate. Most significant, shortly in the mid-2000s, was the community-based abstinence education funding, and this went even further, and this prohibited any other type of sex education to exist in schools. So if you wanted federal dollars in your schools, which also included school lunch money, you had to only teach this specific kind of abstinence-only sex education. And at this time, 50% of all new HIV diagnoses were among people under the age of 25. So now, 2005 is when we really start making some biomedical advances. First, in 2005, non-occupational post-exposure prophylaxis, or NPEP, was approved. And this said if you were able to access medication within 72 hours of a condomless sexual encounter, you could prevent HIV infection from happening. Then in 2006, we had the biggest game changer for HIV treatment with the advent of the one pill, once a day regimen. 2 drug companies worked together to combine their 3 pills into 1 tolerable drug a day. So we went from handfuls of pills every day to just 1 once a day. And that was amazing. And a lot of people were able to get back on treatment. Next, in 2010, after years of studies, the FDA finally approves PrEP, or pre-exposure prophylaxis. And now this means that we have 1 daily pill that will prevent HIV. The first time since the beginning of the epidemic that we've had anything other than condoms for prevention. And this is huge, and it completely changes the way that we talk about sexual pleasure and HIV. And I want to really thank Marcus Cruz Sanchez and the Kind Clinic for this awesome illustration he did for a PrEP awareness campaign. Now, one downside with PrEP is it's completely controlled and monopolized by 1 drug company who controls all access to it. Boo, yeah. So also in 2010, the federal government issues the first national HIV/AIDS strategy with a specific focus to end the epidemic in the US by 2030 and putting more money into it. And then last but not least, in 2017, after 3 decades of study and evidence, we can unequivocally state that a person on effective HIV treatment can't pass it on sexually, period. And I want to say this one more time for the people in the back. A person on effective HIV treatment can't pass it on sexually, period. And again, we're on the back. Let's check it out. And now we're on the cusp of a new sexual era, especially for queer communities who have been told to live in fear and stigma since 1981. So let's talk about these 2 big game changers, PrEP and treatment as prevention. So PrEP is for people who don't have HIV. It's a daily medication. It takes 7 to 21 days before it's effective, 7 for anal, 21 days for vaginal, and it's 99% effective in preventing sexual transmission of HIV. There are 2 drugs that are currently FDA approved. They're both owned by that big monopolistic drug company. Boo. Treatment as prevention is generally referred for people living with HIV, and at this point it's also generally a daily medication. Once you're able to achieve and maintain viral suppression for 6 months, it's reliable and 100% effective in preventing sexual transmission of HIV, period. There's several HIV treatment options available, and you might start seeing this referred to as U equals U, or undetectable equals untransmittable, which is the marketing campaign that's being pushed out by activists for this. So now I want to talk a little bit more about the work that I've been doing and show you some of the ways that we're using data to propel systemic change. So if we want people to do something different, if we want to see a major disruption in how prevention and treatment services are offered, we have to break through the myths and old stories that people carry around with them. And we have to use a combination of storytelling and hard data to help people understand what's actually happening. Data can mean a lot of different things. The things that I see and experience, the stories that you share with me about your experiences, and objective data from like medical records and surveillance systems, all of this is information that makes up data and can help inform our decisions. Each of these kinds of data are important and help us not only see the full picture of what's happening, but also help us appeal to the emotional and rational parts of the brain, which is important when we're trying to get people to make big behavior changes. So this is what I bring into the room. All of this objective data that we collect from around the state. And this data can tell us what is happening. So it can tell us what populations are most impacted by HIV. It can tell us what health disparities exist. It can tell us what parts of our system are working well. And it can tell us what parts of our system aren't meeting the needs of those communities who are trying to engage in them. But what data is never going to tell us is why these things are happening. If we want to know why, if we want to be able to contextualize this data, we have to bring in those stories. We have to connect the hard data to people's experiences so they understand how to use that to make change. And then if I do my job right tonight, you're gonna leave here with more questions than you came in with, and you're gonna leave with a lot of whys, and the best people to answer those whys are the people in your community. So let's take a look at the objective data, and to start, I just wanna get a little sense of where Texas stands nationally first, and then we'll drill down. So Texas is a very big state. It's easier to get to San Diego from El Paso than it is to get from El Paso to Beaumont, right? It's a huge state. So unsurprisingly, Texas is fourth in the total number of people living with HIV behind New York, California, and Florida. When we look at new diagnoses, it's even more centered in the South. 50% of all new HIV diagnoses come from the South. Texas is number 2 behind Florida. Thank God for Florida. So when we look in Texas, it's probably no surprise to anybody that Houston and Dallas make up the largest proportion of folks living with HIV in the state. Over 50% of all people living with HIV in Texas are in these 2 regions. And then when we start to round out with our other major regions, San Antonio, Austin, Fort Worth, these 5 areas are 3 out of every 4 people living with HIV in the state. Now, if we want to continue further, if we were to consider a geographic region, the 6th largest region of people living with HIV in the state is the criminal justice system. And at any given time, over 4,000 people are living with HIV in the criminal justice system. The largest proportion of those are in the Texas Department of Criminal Justice. Now, when we go back to our geographic regions, we're going to go to our borders. Brownsville and El Paso, and then East Texas with Galveston, Tyler, and Beaumont. These 10 regions, plus the criminal justice system, are 90% of people living with HIV in Texas. So if we want to end the HIV epidemic in Texas, and as goes Texas, so goes the nation, right? If we're going to end it here, it's going to be focusing on these areas and these regions. So now that we know where people are living with HIV, it's important to know who is most impacted by HIV. And in Texas, these are the populations that are most disproportionately and disparately impacted by HIV. And Texas is unique. Most states only have to deal with 1 or 2 communities. Texas reflects the national epidemic. We look like the United States. And we need to understand the experiences of a broad group of folks. Now, we know Texas is a big and diverse state, right? So depending on where you live in Texas, who is living with HIV is probably gonna look really different. So, for example, we can look at the Texas-Mexico border, and we can easily see that the majority of folks living with HIV are Latinx, specifically Latinx, gay, and bisexual men. Compare that to our other border in East Texas, and we see a vastly different community. A system of care that works really well in Brownsville that's largely Latinx won't be responsive to the needs of a community like Beaumont, where we see much larger proportions of Black folks living with HIV, much larger proportions of people who acquired HIV through injection drug use. And all this is to say that there's not one system of care or one pathway that's gonna work for the state of Texas. If we're gonna be able to end the epidemic here, we're gonna have to be able to respond to each individual local need and understand the communities that are trying to move through those pathways. And this means empowering all these communities to understand and use all available data. So there's some other characteristics that we can look at that can help inform us, like age, right? So when we look at people living with HIV overall in the state, only a small proportion are under the age of 35, only 25%. The largest proportion are over the age of 45. But when we start to look at the ages of our priority populations and break it down, we start to see differences. So again, at the state level, only 25% of people living with HIV are under the age of 35, but 50% of Black, gay, and bisexual men, 50% of transgender women are millennials or younger. And already we can start to see and think about this data point. Do 25-year-olds engage with healthcare in the same way that 50-year-olds do? No, right? You know, are we gonna make them walk along the same pathways? And we can start to understand what it looks like to prioritize within these groups. We're not just talking about all Black, gay, and bisexual men. We're talking about a younger population. And we wanna focus mainly on young Black, gay, and bisexual men. What would it look like to tailor a health pathway for a young Black, gay man? How would it look different than it looks now? And we see this trend continuing towards younger folks when we look at new diagnoses as well. 60% of all new diagnoses are among people under the age of 35, and this is not a new trend. This is how it's always been. And this tells us not only about who is coming into care, young and primarily Latinx and Black, gay, and bisexual men, but also who we need to reach for testing, and who on the flip side is appropriate for PrEP services. So let's talk about PrEP first. There's not a lot of available data about PrEP usage because of that aforementioned drug company that monopolizes PrEP and doesn't release its data at all unless it wants to, and very rarely. So I only have a couple of slides to show about PrEP, and it's really the most important things. First, the South, which remember is 50% of all new HIV diagnoses, has the lowest PrEP rate in the nation, almost half of that of the Northeast. And then one of the most other reliable data points we have come from the CDC. So the CDC has said they estimate that about 1.1 million people in the United States could benefit from PrEP, could use it. About 500,000 of those folks are Black, about 300,000 of those folks are Latinx. And when they examined retail and mail-order pharmacy data, only 1% of Black folks and 3% of Latinx folks had filled a prescription. So even with this limited data, we can see that the folks that need access to it aren't getting it. So now I want to finish with people living with HIV and access to treatment because that's where we have the most data. Texas has more data than almost any other state. And so we're able to get a better picture of what systems of care look like around the state. And we have some large goals to measure against as we move forward. And you'll probably hear this referred to if you ever talk about HIV as the 90-90-90. We want 90% of people living with HIV to know their status. We want 90% of people who know their status to be on treatment. We want 90% of people who are on treatment to achieve viral suppression. And we think if we're able to achieve these goals, we'll be able to see a significant decrease in incidence and end the epidemic as we know it. Now, because this talk is really short, I'm mainly only going to focus on retention and care for this to show some of the data that we have to look at. So we're going to start with the state. At the state, we're at 70% retention and 86% in-care viral suppression. So already at a glance here, we can see that our biggest priority in the state is creating better opportunities for people to get in and engage in care. Here's Austin. Austin has one of the better systems in the state. We're a little bit higher than the state for retention, and Austin has achieved our goal for in-care viral suppression, right? So Austin, just like the state, really needs to focus on what they can do differently to engage more people in care. And one of the ways we're going to get there is by having a different conversation about community needs. So a lot of my work is to facilitate these conversations in communities with people who are living with HIV and people who are directly impacted, and working with them to create different ways to access prevention, care, and treatment, and what other services are needed. And one of the ways we can get there is by making sure that we're focusing and prioritizing those folks who have the greatest impact on the system and who have the fewest opportunities to achieve our goals. And so one of the things that I've been doing to try to help visualize this in an easy and digestible way is using a stoplight system, because everybody knows how a stoplight works, right? And this is the part where I'm going to ask you to help me out a little bit, and I hope you can do it. What do you do at a green light? Go for it, right? So here we're achieving our goals. We want to maintain these current practices, so we can look to these areas for promising activities, right? That we can share around the state. What do you do at a yellow light? Okay, and the rest of Texas, they blaze right through that intersection. Just FYI to let you know. But if you're going to do that, you want to slow down. You want to make sure that you understand what's coming around, what's happening, what's with you, right? This may not be a priority. We want to make sure we're not missing anything. And what do you do at a red light? Hard stop, right? These areas are the furthest away from achieving our goals, and this is definitely when we want to stop and really understand what's happening. So we don't have a lot of time to dig in and have a conversation about all these data points, so I'm just going to run through some of the ways that we can visualize it. First, we can start with maps, because everybody likes maps, right? Yeah. So geographically, yes, maps, cartography, fuck yeah. So here's retention and care, and already we can see at a glance that not just the state isn't reaching our goals, but no area in the state is reaching our goals. However, in care viral suppression, we see a lot of differences, right? And we can take that earlier knowledge we have about where those big areas are, El Paso, Beaumont, Houston, Galveston, and we can start to look in there and say, let's focus on those and understand a little bit more about what's happening. So here we have our stoplight system again. We have those big areas. Each of these bars represents the ranges of retention rates, right? So for example, in Houston, our populations are achieving retention at 64% to 75%. The longer the bar, the greater the disparity between populations. So as we start walking folks through, we can start seeing consistent trends around the state, regardless of region, right? We start to see the same populations having more opportunities to achieve retention, the same populations having fewer opportunities to receive retention. Latinx women in El Paso, people who inject drugs in Galveston and Beaumont, right? And so we can already see kind of at a glance that white, gay, and bisexual men have the most opportunities to receive attention. And it's not because they care more about their health, right? It's because the system creates more opportunities for them to access and engage with it. And when you see the same communities having more opportunities, and you see the same groups having fewer opportunities, regardless of region, then you have to stop talking about individual behavior. It's not about why doesn't somebody just go to the doctor, or why doesn't somebody just take their medicine. That's not the problem, right? Population disparities like this tell us that our systems aren't creating the right opportunities for folks to fully engage in care. And if we want to see a change in these outcomes, if we have to change what we're doing. It's not about you, it's me, right? How and where and who is offering those services and what services they're offering. And then we can even start to look closer within populations, right? So for example, we can't talk about all trans women the same. We know that the experiences of Latinx and Black trans women are different, and that plays out in our data here. We see the same disparities within the trans community that we see within the cisgender community. And so that again kind of directs us on, if we're trying to create pathways for the trans community, we have to really look within each of these different groups and understand how all these intersecting identities come into play with their experiences. And in larger areas, and especially monolithic areas like El Paso, we can also start to look at things by ages. So here's Latinx, gay, and bisexual men in El Paso, broken out by age. We can kind of see what the age distribution is and who's gonna have the most impact on the system, right? So we're gonna sit with like 25 to 64. This will be comparing Latinx, gay, and bisexual men with Latinx women in El Paso. We're only gonna look at men. But just if we kind of start to pop up where their retention ranges are, we look at the size of those populations, we can start to see things that pop out. And these are the questions we want to start asking folks. You know, what are the experiences of Latinx, gay, and bisexual men 25 to 34 in El Paso? Why do they have so many more opportunities than anybody else? Especially those men who are just slightly older and slightly younger than them. You know, why are the experiences of these age groups so similar and so much lower than these age groups? And if we start to ask communities these questions, we start to really dig into what the differences are in experiences, we can really understand how we need to change our systems to be responsive to the needs of folks instead of making people try to fit into our box. Almost done. I think I'm almost good on time too. So we can see the same disparities existing across time too. Here's Austin, over 3 years, right? When you see the same disparities existing across time, across communities, across ages, again, we have to stop talking about individual behavior change, and we have to focus on disrupting these systems that we're propping up. HIV isn't the thing that's gonna kill these communities. It's a symptom of all the systemic issues that these folks are facing. And if we want to end the HIV epidemic, we have to start listening to our communities who tell us what their priorities are, who tell us that they need holistic health, who tell us that they just need fucking safety, who tell us that they need safe housing, who tell us that they just want to live their lives without being harassed and assaulted and dismissed and diminished and murdered. And we need to both center our programs and our work around meeting those needs and simultaneously tearing down the barriers that we've created to maintain oppression and that prop up white supremacy and misogyny. And that's the only way that we're gonna end the HIV epidemic in this country. So we joke around my office that it's often at this point in the conversation that a lot of folks say, somebody should do something about this, right? And I want to tell you this, it's you. You are the somebodies that should do something about us. Every single person in this room has something they can do to influence action and do something about this issue. And I'm going to give you 3 easy ways right now that you can get started. So if you want to, you can take out your phones, get your cameras ready for some QR codes. They're going to be up for a couple minutes. First, this is our statewide Ending the Epidemic movement. It's called Achieving Together. It was developed by and for community to focus efforts in order to end the epidemic in Texas by 2030. Texas was the first southern state to do this. And we were one of the first states nationally to do this too, just behind some of the other large areas. This will give you a high-level overview of what the movement looks like at the state level in different communities and a lot more data if that's really what your jam is. Now, if you want to get more directly involved locally, you can engage with the awesome Fast Track Cities folks. Fast Track Cities is an international movement focused on helping cities leverage partnerships with city government to fast track ending the epidemic locally. And I think Austin will be the first Texas city to reach 90-90-90, and you can all be a part of that history. And then finally, the children are the future, right? That's what they tell me. And for the first time since 1994, the Texas School Board of Education is updating the sex ed curriculum. Right, and that's really exciting. So the Texas Freedom Network is leading the charge on this to ensure that this update includes medically accurate and affirming information. So you can go here to find out all the amazing work that they're doing and how you can support that. And that's my time. Thank you so much.
I didn't see any on Twitter yet, but remember that's an option. So let's see what we got going on. Oh, that like helps a lot. All right, in the back, what you got?
So I was wondering about
if I can try to summarize, are there any times where PrEP might fail?
Well, so PrEP is for people who don't have HIV, right? So yeah, and it's a really similar drug. Like PrEP is Truvada, treatment is Truvada plus this other drug, right? So it's really similar. So there's a great website called the Prevention Access Campaign, and they answer a lot of questions that go into those details because there can be viral load blips, right? That can happen a lot. And most of the time, those blips don't have any impact on onward transmission. Now, a lot of the studies were done based on 200 copies per milliliter. That's considered undetectable for those studies, because at the time, that's as low as viral load testing could go. Now it can be a lot more sensitive. It usually measures to like below 20 copies, but a lot of the testing was even done on like 1,500 copies. So even with these blips, it doesn't really have a huge impact. Most folks are getting tested quarterly until they're pretty maintained, and then it's biannually or annually. And so there hasn't been any issue with that. But yeah, there's a lot more detailed information if you want to know kind of the mechanics behind it on that.
All right, we're off to an excellent start. Who's got the next question? Let's try over here.
Do you think that medical professionals shot themselves in the foot by trying to make people overly safe instead of really teaching people how to have safer sex? You mentioned barebacking in your title,
Right.
and not teaching, saying condoms is the only way, and not teaching people like that lube fits preparation and actually really effective.
Do you think medical professionals made an error by emphasizing condoms only as opposed to other strategies for prevention?
Sure, and I'll be upfront, I hate doctors. Not all doctors, there's some good ones, right? But there's a lot of really tolerable ones. I mean, our healthcare system is really built for the insurance industry, and it's really built to like have this paternalistic view. And so, I mean, I think there were, and I was right there with it. I mean, forever we only had condoms, and so we had to try to talk to people about using condoms because it was one of the better options. Now, where we got stuck is that so many people were uncomfortable talking about those other options because they feel like, oh, this is what you should do, and I don't understand why you wouldn't do the healthy thing, right? Not understanding all the things that are happening in people's lives. And I think especially right now, a lot of folks that are hardcore entrenched in the HIV community are really uncomfortable talking about condomless sex. The AIDS Healthcare Foundation, Harvey Weinstein, not Harvey Weinstein, that's a different. But AIDS Healthcare Foundation has been really opposed to PrEP. They talk about Truvada horrors a lot. There's a lot of conversation. The same thing that women saw in the 70s with birth control, talking about, oh, if you give people birth control, they're just going to be slutty, like there's something wrong with being slutty, right? And so I do think that, and I think a lot of it has happened in schools where the only conversation we have is about, even when we're talking about polyurethra contraception and not understanding like lubricant and how important it is, right? I just had a conversation with a 17-year-old friend of a daughter of my friends who had never heard about lubricant before, right? And so they're not, yeah, I know, right? It's so crazy. Tell your teenagers about lube, it's really important. Yeah.
Excellent. All right. So there was someone in maybe the third row that had a question. What you got? Is a prescription required for PrEP?
That is a great question. So most states, yes. California is the first state to pass legislation that said that you can get PrEP over the counter without a prescription. Denver or Colorado is getting ready to try to push some of that through now. So there are a few states that are starting to look into what that could look like, but California is the first and the only one. In Texas, you have to have a prescription, but you can get PrEP through apps like Nurx and those other online reproductive health apps or whatever. There's a few of them that are out there that do telehealth. So there's a few different ways besides just going into a doctor. And Austin, there's a lot of agencies that do it. The Kind Clinic, Center for Health Empowerment, A Services Austin. I'm sure I'm leaving somebody out, and I'm sorry if I am. But yeah.
What's the typical cost?
So that's the big question, right? So in the United States, the typical cost for PrEP out of pocket is around $1,500 a month. And every other country, it's around $8 a month. Truvada, the drug company that shall not be named, has a patent on it, and they've been extending it. This is a whole bar talk. There's an hour I could talk about Gilead and all the fucked up things that they've done. They used our taxpayer money to do this research. So it's the patent's technically owned by the government's suing Truvada over it. Most people can't access PrEP for free. Now, the Gilead does have a lot of patient assistance programs. It's fairly easy to get onto it, but it requires a lot of maintenance. Every 6 months, you have to send in paperwork. You have to jump through a lot of hoops. Like almost every other program in this country, there's a lot of paperwork involved in it. So you can get access to it, but you have, and that's part of the challenges with access. You have to be ready to work really fucking hard, and you have to talk to a lot of obnoxious social service people. And I'm a social worker, but we're terrible sometimes.
All right. I'd like to note that we went rogue for a second there with just like shouting out questions and answering them. Don't make me. Don't make me. I'm feeling real spicy. So, with that said, we have a Twitter question. And the Twitter question is, what major negative effects has abstinence-only sex ed had on this data? Is there meaningful data trends that can be observed since the sex ed update that happened recently?
So I'm not sure about what sex ed update recently would be referred to. I mean, we can see in Texas has huge rates of like teen pregnancy. There's a real big syphilis issue right now in Texas. You know, I think we can see when we look at the outcomes of like poor reproductive health or poor reproductive health education and all the STIs that can come from it. We do see the outcome of that, especially in Texas. We do have some of the highest rates of syphilis in the country. We do have some of the highest rates of HIV in the country, some of the highest teen pregnancy rates in the country. Like, we're number one.
Neat. Okay, so let's see. I've been looking over in this direction because it's easy to look that way. What do we got over here? It looks like right dead in the middle.
Are there any side effects to PrEP that they go to start?
Are there? Are there any side effects to PrEP?
Not many. Most HIV treatment these days is actually really tolerable and doesn't have any more side effects than most other medications to manage chronic diseases. Some people, so Truvada is a little bit different than Descovy. Those are the two meds. Truvada has, some people might have kidney issues with it. You just have to monitor your renal function. But not really. I mean, all medication's toxic, right? Like any pill you're going to put in your body is going to have some kind of toxic effect on it, but not anything like what early HIV medication used to be. And so it is really, really tolerable. There's a lot of anecdotal Facebook groups where people talk about their experiences with it, and there's just not enough of it. Descovy is supposed to be even more, slightly more tolerable than Truvada, but really no major difference, other than I think there's like a higher BMI that comes out of it, which I don't know how they think they're going to get the gays to take medicine that's going to make them fat.
All right, we've got time for one more question. Y'all have been very good, so you get one more. Who has the best question? I don't know if we have you wrestle, I'm not sure. Dun, dun, dun. All right, I'm gonna go ahead and go with you because you're in an underrepresented section. What you got?
Why does Texas have so much more data on people living with HIV?
Why do we have so much more data?
Thank you. That's a great question. So in 2010, the Texas legislature passed a law that required all viral loads that are ran in the state to be reported. So we get about 95% of all viral loads that are ran. Also, HIV is a reportable condition. So any lab or doctor that potentially sees a test that could indicate HIV is required to report it to the state health department. And so we have sharing agreements with Medicaid. We're one of the few states that has a sharing agreement with Medicaid, which doesn't mean a lot because we didn't expand Medicaid, but we've got that data. And we also have sharing agreements with some of the largest private insurers in the state. So we have a pretty robust surveillance department that takes all this data in annually and creates a combined data set. And we probably have some of the most robust data in the nation because of that. And because of a lot of other things, that also means we have some of the best health data around the trans community because we have so many more trans folks in other states.
All
We're
right.
like number 2 behind California when you look at numbers. Yeah.
Awesome. What a great note to end on. Thank you so much.